what we're doing today. So in a minute, I don't know the presentation was going to come up. So I don't know where the presentation is. Where to pull it up. I'm Gus Ferrer. I'm a pulmonologist. I trained in pulmonary medicine in Cuba. I left Cuba. I'm not going to tell you when, but a long time ago. I left Cuba about 20 years ago, 25 years ago, and I worked in doing research with communities, native Indians of the Orinoco River. Spent 2 years in the jungle with an incredible team of people. One of the best times in my life. Young, in the middle of the jungles, what best? I'm doing research, which is what I love the most. So I came back and I did my training in pulmonary medicine. I did my medicine in Texas and then went to Washington, D.C. for pulmonary and critical care, and then joined the Cleveland Clinic where I worked on upper respiratory infections. And we opened a chronic cough center. And within 3 years of doing so, we realized that first we were following the steps of a cough clinic that was opened in London around 2006. And the reason that they opened a cough clinic is because they did a study at Massachusetts General Hospital, and they found that the second most common reason for people going to doctors across the planet is cough. Second most common. They also looked into it, how many schools out of the top 100 med schools in the planet has a curriculum to teach doctors how to handle chronic cough? 0. Why? Because in the last 50 years, we focus entirely on big stuff. We focus on diabetes, hypertension, and all the other stuff. And we totally forgot about the common things. And common things are responsible for a number of days lost of work, and incredible economic impact. Large number of co-payment goes straight to just handling simple coughs. And unfortunately, most of my colleagues, and I was in that pocket in my lifetime, do not know how to handle chronic cough because it's never been, part of any curriculum. So Cleveland Clinic gave us the opportunity to open up, and we launched our chronic cough clinic. And within 2 or 3 years of doing so, we realized that 9 out of 10 patients that were coming, we were doing research on everybody that was coming in. 9 out of 10 patients were using lots of stuff from the over-the-counter, and lots of remedies from grandmas, and lots of remedies from whosoever gave them for the cough, and we couldn't get our hands around it as a clinician. So I partnered with a herbalist from Harvard, and we wrote our first book. And it's a book written for the general people. It's full of stories, and we talk about natural remedies and the evolutions of that and the combinations on over-the-counter. So I went for the launching of that book at a Cleveland Clinic Wellness Conference in Las Vegas, and that's when I met Nate and Chad. So in my book, I mentioned clear, and I didn't know these people. And I mentioned clear because I was exposed to through my friend at Harvard that she'd been using for her patients for many, many years, and I'm talking about 18 years ago. So, we looked into the research that had been published, we put it in our book, we talked, and then we began this partnership to do some research and collaboration together. So we launched it a few years ago, the idea of continue to explore the value of clear in allergies and immunology and respiratory illness and all of that. And then came COVID, Our lives in this planet been marked BC, before COVID, and after COVID, So when COVID came, we were in the middle of launching some international trials to look into allergies and the treatment of allergies using clear. But in some of the studies that we have done, we've been collaborating in developing a nasal spray that contains chlorpheniramine plus clear. And And chlorpheniramine, which is an antihistamine, 3 years ago has a study that shows that is extremely powerful against influenza A and B. So we began to look into this idea when COVID came about, if this could be something that can treat COVID. So we began to reach out to people, and we found some friends that pointed to the Institute of Virology right here at Utah State University. And that's when everything began. So we have done some study that I'm gonna go over that in a minute, and also the things that we're doing and where we're going with all of this. So what's the game plan? This is clear, you guys know this. So our first study was back in March. We did a study with Utah State University. They tested the spray with chlorpheniramine, and it was really good against COVID. And then we decided to look into all the other components that Clear has. And long story short, the Clear, the one that you guys have here, this one, was able to eliminate 99.7% of the virus within a few minutes, 10, 15 minutes. Mm-hmm. So then the study was sent to Geneva University as kind of a referral lab and a second hand into the study. And they looked into it, and they found actually similar results. They found that not only it was able to eliminate the virus within 10, 15 minutes, but also by diluting the spray, by adding water, let's put it that way. By diluting the spray all the way to a dilution in 1 in 18, you can kill the great majority of the virus. So showing that the spray has an incredible potential to kill the virus. Alongside that, we began a campaign to try to see, we spoke with the FDA, we had spoken with everybody. And what happens is that in this incredible, fascinating country, I'm originally from Cuba, but my heart is here. I think that this is the best country in the whole planet. But things happen, and momentums are different. COVID came when we have an election in the middle, and we have all these issues going on. And historically, that point, governments and educational places to focus on big stuff. And this is not new for our history, for the planet. So the main campaign all the way from the beginning has been in finding a vaccine to cure COVID. But in between, there is a lot of people looking into other alternatives from here to there, from here until we get a vaccine. There is still a potential for a lot of people to get sick and die. So during the summer of this year, June, this year seems to be very long. During the summer, North Carolina University, Chapel Hill, they did a study that they mapped the infectious process of COVID-19, and they found that 98% of the infection begins in the nose and trickle down into the lungs and to the systemic damages that we see today. That's kind of a landmark study that actually opened up this idea that we have been working for a while, that opened up for other people to start looking into, hey, how about if we tackle this issue right here at the nose? This past week, 2 weeks ago, in one of the most powerful medical journals, they published a study that they use iodine, povidone iodine in intranasal spray. There's another group that has used nitric oxide. And so in the last 2 or 3 months, there's a large number of studies coming up to consider tackling this phenomenon here. Even the vaccine world, so people published a week ago that if we're gonna find a vaccine, it has to be highly effective up here. Even the company Remdesivir that has this IV medication that we use in the hospital today, they're looking into switching into intranasal because studies on Remdesivir are beginning to show that there's not as powerful as we thought. So, it is a great momentum for the things that we're doing. And along those lines, less than a month ago in Tennessee, a group of researchers at University of Tennessee, they looking for another chemical component in a nasal spray that can actually kill COVID, and they combine it with xylitol. They found that xylitol in that study blocks the entrance of the virus to the cell. So it happens that became clear that it is very likely part of the solution for what we're facing today. So we have a nasal spray that has GSE, that was proven in these two studies that we mentioned here that can kill the virus in no time, and you have xylitol that blocks the entrance to the virus. So you basically have the perfect combination for intranasal delivery. But what is the challenge that nasal spray they have for years? And I'm not going to ask you that question that I asked the other group, but we'll move it on. So this is going to be published, the combination of those two studies, in the journal Antimicrobial Chemotherapy from Oxford. And this is a case, a series of patients that we're publishing this week that we launched a clinical trial about a month or so ago from Miami. And we have enrolled today, between all the places that we're working with, we have about 20 plus patients enrolled. The first group of patients that we looked into it, we pulled the highest risk patient, 3 of them, asthma, diabetes, hypertension. One of them is a smoker that was smoking all throughout treatment and everything, low oxygen and all of that. And we put it on clear, these people, for 7 days. We repeated the PCR as soon as they felt good. On day 3.5, between the three patients that we have, they were feeling much better. On day 4, we did a PCR and it was negative in these 3 patients. And then we repeated that again on day 6 and on day 7, and it remained negative. So they were cured in less than a week or so. And if we follow the trends of the research coming out everywhere, and that's the reason the CDC recommend isolation for 14 days, is because most people remain positive beyond the 10, 14 days. So with that said, the patients that we have today, we're analyzing daily, those that are finishing the trial, and it's exactly the same picture. We have 20 plus patients now in the trial, and 90+% of those patients at day 4, they become negative from COVID. But we have done something. We are now engaged in collaboration with other places. We're between the end of this week and next week, we're launching the study in Dominican Republic. We already have about 10 patients in Venezuela, and we have some other Central American and other places that we're in conversation today to do so. So what's next, despite or beyond COVID? 2 things. One is, we don't want to forget about that we have been trying to get clear within the guidelines and the recommendations of intranasal therapy for allergies. The World Health Organization sponsored about 10 years ago a new guidelines that focus entirely on intranasal therapy, not only because of the need to find something for allergy, but the nose will become, and it has become already, the place to deliver medication. And the reason is, every time you take a pill, the medication has to go through the liver, and part of that medication is cleared by your feces, and a small percentage is the one that has the effect. That happens with every single antihistamine. So it's only about less than 1/3 of the medication that gets into the nose. So when you apply it intranasally, you're using 100% of the power of the medication. You can use less doses. It doesn't go into the liver, it doesn't go systemic, and it doesn't give you the side effects of antihistamine that put you to sleep and all the other things. And that opened up for many people to study vaccines. Many people to study, even insulin was prepared one time intranasally. And they also have studied antibiotics to be delivered intranasally for many options of therapy. But many of them have failed, and I'm going to tell you in a minute why they have failed and what are the things that we're doing. So as a next, we don't want to forget the allergies. And we want to try to see in the next few years, in collaboration with the World Health Organization, we have a team of people working on that, to prepare all the research that we need to be part of this first table of recommendations in the treatment of allergies. That is happening now. I didn't put it in here, but this year, the European Ear, Nose, and Throat Society, for the first time, included xylitol into their recommendation of intranasal therapy. So I think that this is something that we cannot forget. But what happened with intranasal therapy? Intranasal therapies have failed in many occasions because the doses can change depending on the way that you use the nasal spray and the nozzle. So if you want to have a really good doses of anything that you put in the nose, you gotta have a specific angle in the nose and penetration into the nose. And it's not secret for any of us. It is just like this young lady. You know, if you really want to give something intranasal, you got to grab people by the nose and jab it in there, because it's going to be, most people move the head and it becomes a problem. So we've been working on that. And we have tracked all of this. The influenza vaccine was put intranasally about 8 years ago. And within 3 years, it was a total fallout, because it was not as effective as the injected one, because people were moving the head and the pressure and all of that. That launched an NIH-sponsored group of people about 4 years ago. That they began to look into what are the issues that we have with intranasal therapy. And they did something called fluid dynamic, and this is kind of the summary of the things that we also have been in collaboration with some of them. So if you incline the nozzle up, you lose about 70% of the doses. If you incline the nozzle, the tip of the nozzle down, you lose about 60% of the doses. And if you put it straight up, not straight up, 45 degrees, you gain almost 100% of the doses that you deliver. And also, how deep you go into the nose is important. This is another study on computerized doses, and they found the following. The pressure has also to do with not delivering the right doses. Most of you probably has experience that you stick the nozzle into your nose and you have a sensation that is not comfortable. And it's because of the pressure. When they look into the pressure, the angle is, again, it's like having a pressure cleaner against the wall. And you put a pressure cleaner in there, you're gonna lift, you're gonna break off the painting and all of that. That happened in the mucosa. That's the reason you feel pain. So this group of researchers, and I'm gonna show you the part that we have done with them, they look into the nose, and this is actually a group of studies that we collaborated with them. They map nose of patients, and they use CAT scan to see in 10, 15 doses how moving the angle affected the liver, but also how deep you can go into the nose. So we began to develop a nozzle that help us break that or overcome the objection of using nasal sprays. And the first time that I presented this to my team in my group of fellows, this is outside everything, in Miami, all of them, they told me, I haven't been using mine every day because I have a little sensation in there. But here's what happened. When the nozzle, the traditional nozzle that is standard across the board, you go to any pharmacy and any nozzle that you see has exactly the same design. It is pressure coming around a tube, and the first 2.5 millimeters is a concentration of pressure. But if you have to stick the nozzle into the nose 1.5 centimeters to bypass this area here, the nasal valve. If you put the nozzle here, you're not gonna get not even 50% of the doses. You gotta bypass this. So if you bypass this 1.5 millimeters into the centimeters into the nose, and you put a 45 degrees and you squeeze that, the first 2.3 millimeters are gonna be jabbing a tremendous pressure into your nose. So this is actually a problem for most of the nozzles that we have. So we began to work with a group of engineers, and we developed this. We have a nozzle that it goes circular. It's called vortex, what the engineer called. And what it does is kind of atomize the nasal spray. And this group published this study. This is NIH-sponsored study that they looked into how we can increase actually the delivery into the nose, and they found exactly what we've been studying for a while. You got to stick at 45 degrees and then penetrate 1.45 centimeters into the nose, which is this entirely is 1.8, so you got to get close to here in order to really have a good penetration into the nose. So we went on and continue to look into the study. This is actually the conclusion of the study, and this is a picture from our office that we did with one of our patients. That we looked into, how is the right angle to deliver this. And this is actually the summary of all this. I think it's a 45-page study. That if you put a 45 degrees angle the spray and you penetrate 1.5 centimeter into the nozzle, kind of half in this tip, you can get exactly the same doses that you need for every nasal spray. So we then had a second problem that we've been trying to target for a while with antihistamine in our own research. So a group of engineers that I have been working for a while, we developed a prototype of a nozzle. Long story short, it coincidentally came out during the summer. And now we have it actually, it's gonna be available here for all the products that we have. And we brought a prototype here so for you to see. This is the conventional nozzle that you see in every pharmacy out there. If you see that the first 2 millimeters is a straight up ejections of fluid. And if you see this nozzle, see the difference? It goes out. Look at this. Now, this travels 7.5 centimeters into the nose. This traveled 3.5, which is the size of the nozzle. You see the difference? Look at this. All the way down. So that pressure was going into the nose of every single nasal spray that we have out there. I don't know if we're going to be able to see the video, but this is the origin of this idea. This is one of my beloved patients that has a genetic respiratory disease. She has alpha-1 antitrypsin, and she's been using oxygen forever. She has chronic rhinitis, and she couldn't use any nasal spray. And every nasal spray that I gave her failed, and she has been my hero, which is the one that helped me design this. And the reason is she was honest with me in every visit. You know, been doing this for a while, that we don't tell the doctor the truth most of the time. So, how you doing? I'm doing fine. Are you taking your medication? Oh, sure. Nobody does, you know. But, you know, she was honest, and she wanted to use it because she couldn't sleep, and she has a lot of issues. And so we went on and worked with her to develop something that, you know, overcome this issue of the objection of putting stuff in your nose. We do that when we're children. We stick beans and whatever into the nose. But once we bypass our teens, we don't want to put into the nose anything. And I think it's going to become necessary to get into that and overcome those kind of objections. So this is what we have developed into our nozzles and the things that we're doing. But this is the spray pattern of these two nozzles. The conventional is this one. This, to get to 100% of the doses, the 100% of the doses, you need to travel around 3.5 to 4 centimeters into the nose, and then remains constant after that. With the new nozzle that we're working with and we have developed, you reach within few centimeters, 3 millimeters into the nose, you reach your 100% and then goes down. So this is where we're looking into develop stuff that teaches people how to put it into the nose. And we have looked into the sensitivity of that, and we looked into what people feel with the different type of nozzles, and this is a study that is coming. But this is actually a combination of the things that we're doing. This is another study that we're publishing, that why we're pursuing a therapy that has two things, and this is our spearhead, the COVID-19 study that we're doing. Why is that necessary? It is necessary because while we wait for a vaccine to develop, we have the potential of spreading the disease, people getting sick, ending up in the hospital, and going into this cycle of prevalence of the disease. So from here until we get an effective vaccine, we're gonna need therapies. And I'm gonna tell you something else. We will need therapy forever and ever, amen. And the reason is the following. This virus has become endemic, like most of the virus, like influenza has done this before. And we need both. We need therapy and we need vaccine. Why? Because the influenza vaccine came about around 20 plus years ago, 1998. Fast forward, only 3 countries in the whole world are capable of giving the influenza vaccine to their people. It is expensive, it takes a lot. Most countries will not be able to accommodate the cost the United States has accommodated a $200+ billion investment in vaccine. It's not going to happen. It's not going to happen. That's the economy of 60% of the countries in the planet. So we need to find something that is safe and effective and help us, curb down the infectious process and get our lives to something close to normality. Because we're going to be abnormal. Normality is kind of abnormal for a while now. So we're working also in this one. Some people ask us about this one. This is the anti-allergy with chlorpheniramine that some of you have worked on this one here. We have worked together on this for quite some time. And I'm glad that you're here that you're going to see this. This is the data of our first group of patients where we studied this for over 30 days. And we compared the newest spray, which is the blue one here. We're publishing this next week. And this is saline. And this is to prove all the research that have been published on salty water, saline that we put in the nose, that it does work, but it has a plateau. You see, all the patients began here, this is saline, but they get here and they plateau. The antihistamine that we have that combine clear plus chlorpheniramine, look at that. It's almost close to normality. There's no a single nasal spray. Yes, sir.
What are you measuring there? Is that the snot score, or is that the
Yes.
congestion, or what is that?
Here we're looking into the daily symptoms, which is a combination of a SNOT 22 plus how people really feel, because we want to try to use new technologies that look into functionality. Because not only symptom, but it's functionality.
So lower on the chart is better,
Lower on the chart is better.
less symptoms.
That's exactly right. And this is when people report daily when they feel the best. So for you to have an idea, all the studies on fluticasone, on Flonase, are hanging around 4 in the VAS scale when they have used fluticasone for 25, 30 days. Most of those fluticasone studies plateau around 4. Our new nasal spray, combined chlorpheniramine with clear, it is almost close to normal. Normal, for you to have an idea on the VAS, which is the daily variance of symptoms, normal 1 is when you get a stuffy, sometimes at night, and that happens to everybody, that is called the nasal cycle, that you turn to one side and one nose goes close up, and you move to the other side and up, or you are sneezing when you get in the sun or something like that. That is 1. So the nasal spray in chronic right now is even take it closer to normal in the majority of the patients. Yes?
For that study that you performed, did you do that study with clear nasal spray without the chlorpheniramine as well to see, is it the chlorpheniramine
clear
or the GSC?
That is clear combined with chlorpheniramine in this nasal spray, the blue one. And this is saline, salty water.
Right, but did you conduct that study on clear?
That is coming. That's what we're working on.
Okay.
That was what we mentioned in the world allergies. We're launching a study that we're studying clear compared with saline.
Okay, because I was just interested in knowing whether it's the chlorpheniramine that is
Or
causing
the
this
clear.
decrease, or whether it's the GSC or xylitol.
I think if the GSA and xylitol combined, there are evidence today that shows that there are plenty of studies that shows that it's superior to saline. Actually there are studies that are compared clear. The Nozuli study, I don't know, I don't have it here, but I can send it to you. They did something similar with clear, and when they compare actually using saline over time, if you think clinically should happen, over time generates inflammation and triggers stuffiness in the long run. And that's what my patient initially told us, that's what happened to her when she uses saline. So Nozuli out of Georgetown in DC, he did a study that he compared saline with clear. And the performance of clear was pretty similar to this. Not only that, within few hours, he actually measured how much the nose opened up after using the clear. They use a really fancy technology, and I can't remember. That was almost. But in Nozuli,
3 minutes.
in 3 minutes, and Nozuli persisted over 3 weeks. The impact of open up the nose. So we are currently working in overcoming all this objection. This is actually the study on chlorpheniramine plus clear in vitro. It shows that also kills the COVID. We already published that. It's PubMed, and this is actually sent by my team. This is kind of fresh. It was added to the World Health Organization literature on COVID review last Friday, I believe. So with that, I'm gonna go to my last thing, and I'm gonna summarize it right here. I strongly believe that this is absolutely true. If you looked into every time we have a crisis in medicine, 9 out of 10 times the discoveries come from something that was already there, that was in a system. And Sir James Black said the most fruitful basis for the discovery of a new drug is to start with an old drug. Formulary is stated in 1998 when he won the Nobel Prize. He discovered the application of nitric oxide. And he was trying to discover something else when he found that. That happened with penicillin, that happened with many, many, many things. So with that said, I just want you all to feel very, very proud of what you do here and help us keep on moving this, because this is truly a family idea. So we need a lot of people, not only you all, but the people doing the research, the patients, and everybody to collaborate. I do believe that this is going to be, I think we're living a great time. I have been in the last 9 months, like most people, discouraged at times, frustrated at others, and with a desire to do something that I don't want to say. But I think that all this is part of life. And when we begin to see momentum creating, we become very excited about it. And our team in South Florida is working day and night. We have a very fantastic team of researchers with a couple of PhD dedicated to help us take this to the next level. So with that, thank you very much. And any questions? Yes.
I had a comment on your original one. Once you get it deep enough, you don't have room to squeeze it. So.
That is true. And I can send you the paper that they actually look into the paper that I mentioned here, the NIH study. What they did, if you looked into, there is only one factory that produces nozzles or patented nozzles in the world, and it's a company called Nemera, and they have that design that every single nozzle out there has, that it is this ejection. When they looked into this paper, they found that the biggest mistake was, number one, that we don't stick the thing deep enough. Number two, it was the angle. So they began backward. And so, but the problem is that they should have highlighted that number three, and this is when our clinical study come to play, a role into that. You gotta keep in mind the pressure, because there's not room when you stick the thing into the nose. But here's what we have. The one that is coming here, I don't know, Chad, this is landing here in December, no? Something like that. The new one that we have, it actually it's a little tiny longer here. It was more rounded like the other one that you have. And you can go half and you still can stick your finger, and it hasn't changed much because we lowered this a little bit to give some room into the hands. So you can actually put it, into the nose. I have a video with a new nozzle, and how to use it. I send that to you.
It'll be on our webpage.
Yeah, that it shows the new nozzle and how you can safely get it about 1.4 centimeter into a nose and still have fingers in there or space to put your fingers and squeeze. Any other questions? Thank you all.
And I'm assuming
I have a
that
question.
Chad forwards all the articles
Same.
where
I have
they
a
talk
question.
about us in the news, doesn't he?
I
will now.
Newsweek article tomorrow? Is it tomorrow?
Should be, it's either tomorrow or the next day.
Do we know the content, how big it is, how much?
We don't.
We done, but I spoke with him 3 times.
And I
So-
spoke with him twice.
Yeah. He called me back on Friday because we were publishing the number of patients, the group of patients on Friday. So he wanna have that data to look it up, and on Saturday we spoke about the patients. So there's a Newsweek paper that he's gonna go through the history of what we're doing here, all the way to the state of the clinical trial, that it should come this week.
So Newsweek, that's a big deal. Should be good.
I'll be tomorrow in Yahoo Financial speaking, about, what we're trying to do here, and, some other that are coming, so we'll keep you all posted.
Next week we'll be on TV on Channel 4.
All right.
Cool.
Thanks, Dr. Ferrer.
Thanks,
That's
Dr.
exciting.
Thank you.
Thank you, Father.
Good stuff.
¿No más?
What am I? Use it.
Okay.
Exciting stuff. Thank you. That was great.
Thank you.
Yeah.
Okay. I'm gonna go upstairs.
I think.
It's cold. Every other time I come in here, it's hot.
Well, I was trying to counter for all the people in here.
Yeah.
Seriously, complain so much.
You want anything?
Oh.
Thank you for that.
My pleasure.
Hey, Ray.
I just, question came up. Hi.
Yes,
It
sir.
occurred to me, the very first, study that was on the first slide, that was done here in Utah, and the one in Geneva, do they, have, I think it's called the N, the number of times that the experiment is conducted?
Mhm.
Don't think I've seen that on those
So-
websites.
You're gonna see in the full paper, when it comes out, the one that we submitted to Oxford,
Oh, that's,
we put in there each experiment, the
Oh.
steps that they have done and how they did it. So, what we have in those reports is kind of the summary.
I stole your.
of
That's what I
everything.
figured. I sent it to a friend of mine who works at a lab downtown.
When you go, you're
And,
all find that missing.
Are you drinking this? As a medical professional?
No, yeah, because they don't have water. Trying to get water.
That was one of his questions. That he came in and said, oh, yeah, this looks good, but where's the end? He was curious about.
Yes, but when it comes out,
I
we're
drink
gonna,
those too every now and then. Guilty
very
pleasure.
seldom.
Guilty pleasure.
But, it's gonna come out pretty soon. We submitted to Oxford, the Journal on Chemotherapy, and they're looking into, when you get it in there, shoot me a text. They're gonna send it to everybody, but it's important that you forward the full paper to them, because, what we did is,